I will show 4 cases here and that I've just cobbled together quickly. The first one, now, this is for those of us that have Siemens scanners, uh, just to be aware of. And I've seen this before and actually encountered it a few times recently, but uh, this is a patient who has a left ventricular assist device. That's not the issue. But when you look at this, the patient does have some biodebris in their outflow cannula. This is real. But when you look at the left ventricle and the inflow cannula, it looks like there may be something else, a filling defect in the inflow cannula. Except you can see that it has a pretty straight line, and there's also surrounding weirdness around this. I have seen this mimic pulmonary emboli in the setting of patients with overlying AICDs or other metallic objects that create artifact like spinal fusion instrumentation. When I saw this, we don't default to getting no IMAR, as you can see on my thumbnail here, or maybe if I do this, yeah, this is with IMAR. So the metal artifact reduction algorithm that Siemens uses, have them do it without, just to make sure. And this is, as you can see, the same series without IMAR. And lo and behold, there's absolutely no thrombus or anything in this. This is all artifact and a consequence of the metal artifact reduction. So maybe the device itself looks a little bit better, but sometimes it can reduce the contrast pool. So this is an extreme example, but like I said, I've seen it mistaken for pulmonary emboli as well. Have you guys seen this? Because I know, well, at least Howard, I know you have Siemens machines.
I've not seen on any outside studies, but
Yeah. But yeah, we just default, I guess, to the metal artifact reduction when they have metal, but it's important to understand that this can happen.
good to know. I wonder if has that been seen on, is that a photon counting Siemens or an
This
EIG scanner?
is, yeah, this is from our, I believe this was done on the Neotome Alpha, but I don't think it has to be.
Okay.
This is was I know I was talking to Sanjeev about this, and he said they've seen this, and I believe it was on a scanner other than their Alpha.
Okay. So it's
Yeah,
not
good question.
yeah.
Yeah, right. We are slowly. Let me make sure this is the correct case. Yeah, we are slowly getting to the changing our protocols and having all of our techs adopt you know, the timing pulmonary emboli studies off of the aorta rather than off the pulmonary artery, because here's yet another example of catastrophe that can happen. This was a study that was done at the outside hospital, and patient was brought, this was just read as no PE. And this one's incredibly sneaky. But right in here, if you can scroll through, when they were brought, there was an echo done and there was a question of a flap. And one of my colleagues looked at this and said, it's hard to tell, but there certainly could be a flap there. Repeat a study with more delay. This is a
Hmm.
big patient too, as you can see. And I thought this was a really good call. And there was, especially there, I'm always nervous when I see a pericardial effusion, especially if it can be hemopericardium like this. But like you can kind of maybe hallucinate in there, but repeat study that was done, and now you can clearly see the flap. I just get so nervous. And there's a portion of what they were seeing right there.
Wow.
And maybe if we go up higher. Yeah, because I mean, this is one of those ones that certainly you wouldn't, like maybe. But yeah, one of my colleagues saw this and it's like, well, if you're seeing something on echo, I can see, I think what you're seeing in here, but you know, this is this is why I'm always scared with the study when there's no contrast in the left heart, especially if there's other signs of pathology like a pericardial effusion that could be hemopericardium.
Hmm.
So yeah, it's amazing. We've been doing it for several months now where we're trying to time everything off the aorta, but I don't know if it's just traveling techs or whatever. We still have a lot of studies that are done off the pulmonary artery. Unfortunately, though, to our knowledge, we haven't run into any specific scenario like this of stuff done internally, but still, we're trying to get them to time everything off the left side.
Makes sense.
Good. Yeah. I've got
Yeah.
two cases like that in my teaching file. Yeah.
I don't know. I've got I don't, maybe it's some of yours too, but like five, six, and I've seen them in all, even in medical legal settings too. This is a patient who, you'll see this study, baseline study, you can see that well, you can kind of see they have cirrhosis here. And this is the next study that's done a few months later. And so they have some process that's confined entirely to the right lung base and right in this area. And knowing they have HCC is the important part here in a case like this. This patient's asymptomatic. Obviously, this is not something we would worry about metastatic disease from an HCC. That looks, doesn't look mass-like. Its area of consolidation is focal. But when I saw this and then digging in the history, and I'll pull that back up here, and you're no surprise, you'll see right where their HCC was, right there, right at the, oh, stop sinking. So right at the roof, segment 7, which corresponds exactly to where this is. And so between these two CTs is when they had their radiation. So this is just, it got better. So presumably some sort of organized pneumonia, whatever, lung injury, radiation related change right in that vicinity of that.
Mm-hmm.
So I think showing this on I think the sagittal too, right there. I mean, it's just a
Oh,
line.
so straight. Yeah.
Yeah, right. You know, sometimes or oftentimes these just get lumped in as infection, inflammation, aspiration, or whatever. But we can be more precise and more accurate in our diagnosis if we just think about the context and take a look at some of the other imaging findings, as in this case.
Oh, yeah.
Yeah.
Good.
Yep. And
Go to the
then the last one, what's that, Howard?
no, go to the medical record. In our
Yeah,
place, the medical record you can open up with just a click. It opens up automatically. So
yeah.
it's trivial to get that information.
Well, are
Yep.
you on Epic?
Yes.
Yeah, yeah. Trivial, maybe difficult with some of the length of the notes. It's there. Takes forever
Yeah.
to dig through it, but
Yeah.
yeah,
Yeah. It's trivial, but in a
yeah.
busy, busy day. Yep.
That dissection I showed you on the too early PE study, I believe was a 27-year-old. This is another 27-year-old who came in. And I just showed this because this is actually after the MR that was done, but I'm just going to go to the CT. They had presented originally with a pericardial effusion that was unexplained, and they had a biopsy, and I think they attempted to debride it. You can see the sternal wires, but things came back. And I just include this because it's rare, but we've seen a few of these. This is the primary pericardial mesothelioma. It's
Mm.
obviously there's some
Wow.
nodularity to the pericardial surface. Some soft tissue looks like it's around or at least near the coronary arteries. Again, this is the PE study, terrible for evaluating viscera, the pleura, the pericardium, but even without that, you can see some of the nodularity and you can see a lot of the surrounding lymph nodes. Um, this patient, trying to remember if they had a mutation when they had a genetic analysis or not. It's been a while since I saw this. Certainly not an asbestos related case in a 27-year-old. It's either bad genes or bad luck or a combination of both. But you know, primary pericardial mesotheliomas do occur just like they occur in the peritoneal cavity and of course in the pleural space.
Right.
So
I don't
yeah,
think
I
I've seen one ever.
think right here is like a good example where it's not just fluid. You can see it has some mass-like
Hmm.
attributes to it. So, all right. Well, those are the four I cobbled together here. I'll have
Perfect.
some better stuff next week. So,
Okay. Great. Well,
and
thanks,
I
Travis.
have no idea how to stop sharing here. I can't
Just
find the toolbar.
okay. Well, whoever goes next can grab it. Howard, do you want to go next?
Okay.
Actually, maybe there can. Let's see. Stop. Yeah.
Yeah.
Can you see my display?
Yes.
Okay.
Yes.
So first case is kind of just strange. So this is a patient in whom I saw this combination of exams, bedside radiography. You have a patient that at some point in time has components of a defibrillator device. And by the way, a lot of people, when I ask them if they know what this thing is, they say, no, it's just, it's part of the defibrillator device, which is a true statement. But I don't know that they always use this, but it's a separate device that you can monitor the depth of manual compression for CPR in some fashion. So it's a separate compression monitoring device. I don't know if they use it, they just put it on, but that's what this separate little electronic thing is. So then you can see now we have on this one more catheters. Yes, this one crossed the midline to go into the right brachiocephalic vein. We have a pulmonary artery catheter in the distal right interlobal pulmonary artery. My first year resident didn't see anything else, but there is this right here. And then what's really interesting is this image. Now you can see that the defibrillator device is back on again. And now we have this item that goes down into the right lower lobe. So here at point time exits here, and it is here. So yes, go to the medical record, try to find some context. It turns out that this patient has a kind of refractory bradycardia that they think is quite significant. They've put in a temporary transvenous pacemaker lead, decided it wasn't working properly. At the bedside, I think they just tried to advance it to see if they could, I don't know how they make that judgment, determine whether it, by advancing it further into the ventricle, they could get it to work. But you can see that was just pushing it kind of exuberantly, and it went down there. So that was curious. I mean, how do you figure that out? At least you know what's going on. So, yep, they took the patient now back to the cath lab, of course, and then they fixed that, put it in the right place, they fixed that, and so on. So, just a very unusual case of a pacemaker lead advanced inadvertently into the right lower lobe artery. This is an interesting case. This all starts in January. This is also potentially a teaser case for, can you see an abnormality on chest radiography, say in the outpatient context, in a patient presumably with some symptoms like cough or fever and thought control. Yep, I'll bring it up here. Very ill-defined opacity here. Yeah, in the left parahilar region. CT done on the same day. Make sure I got my timing of things. Confirms that, yes, it is indeed present. So here it is. Left hilar region, a little bit more inferiorly, mostly in the lingula. Go to the lung window, certainly consistent with an area of consolidation, like that. So as best I can tell, a diagnosis of pneumonia, just community-acquired pneumonia, was made at that time. Then I don't know what happened with the patient in terms of follow-up and so on, but the next time that we see the patient is now more symptomatic and also has hemoptysis. And this is in April. And you can see there is a lot of consolidation in there. And the big finding, of course, is right here. So that pulmonary artery, contiguous and surrounded by that opacity, is now focally dilated. And I presume that this may represent the hemorrhage, as well as down here in this patient that had quite a large volume of hemorrhage. So a diagnosis of, and cavitation. Multiple, actually, but a big one right there. And aneurysmal dilatation of the pulmonary artery. So as best I can tell, they pondered what to do about that. decided that they couldn't really address it by virtue of its location by some kind of interventional procedure. So they did a pneumonectomy. And now I'll bring up the summary slide for you, which is this right here. So there is the history. You can see the patient has a history of diabetes, the time course of things like that, hemoptysis, tachycardia. There's a consult note right there. And did the pneumonectomy. That seemed to go straightforwardly, as you can see there. And any diagnosis you guys going to make? Most likely. Not everyday bacterial community-acquired pneumonia.
Is it cocci?
Fungus. Cocci.
Aspergillus, like
So, yeah, you can see the path description right there. Acute necrotizing granulomatous pneumonitis, embedded fungal hyphae, erosion into the large caliber vessels and bronchial wall, area of consolidation. And there was a description here
Mucor.
that they thought it probably was mucor.
Yeah.
Although they've never cultured mucor forms, but they described the hyphae as resembling the hyphae of mucor.
As opposed to
the dramatic case of
wow,
a fungal infection. Pretty dramatic.
And risk factor was diabetes, right?
Yeah.
Wow.
Yeah.
I don't think I've seen mucor in someone other than neutropenic, like a really, really immunosuppressed patient.
Yeah, I think we've seen it before. I think David showed one. I had one years ago in a diabetic. I think David showed us one some years ago. Also in a patient with diabetes that presented with mucor. Okay, that's my case.
All right.
Thank you for the week.
Thank you. All right.
I'll stop sharing.
Yeah, I can grab it. All right. Do you guys see my Osirix database?
Yep.
All right. So I've got a stack of cases I've been waiting to show. So I can't remember how old this patient is. Youngish. And has this aorta here. So you can see otherwise it doesn't have any underlying atherosclerosis, but you'll see here there's the giant aneurysm sac. I suspect that's just there's this gas here. I suspect it's just the esophagus being pancaked, hiding right in here. I don't think it's actually in the sac there. Usually we think of atherosclerosis, but in a young person, you got to think about it. And the shape of this thing makes you think this is a mycotic aneurysm or infectious pseudoaneurysm, and that's what this is. This is a chronic aortic aneurysm from tuberculosis, which I haven't seen this crazy ever, but you can see it's just this huge entire descending aorta, and then it perfectly normalizes again. So, and then that was, this was it 4 years ago. So it's just kind of been hanging out there. So they presumably got a TB aortitis and undermined the wall, and TB does cause a lot of scarring too. So maybe that's why it's just kind of hanging out there. But I don't know what you do for this sort of resecting the entire descending aorta and grafting it or doing a stent graft, but TB aortitis.
It looks like at the one level, the process was going through the aortic wall into the adjacent lung by direct extension, like right over there.
Yeah, or
looks
right
nasty,
there,
maybe,
or just compressing it. Yeah, who knows?
Maybe. Wow.
Yeah, that was just a bad one. Something we don't see every day. This is a cool case. So this patient presents with shortness of breath, hypoxia, and has this diffuse abnormality. And we've talked about the differential. It has this nice subpleural sparing. They got a CT scan, which doesn't really help. First choice, you might think pulmonary hemorrhage. some sort of, it's so symmetric. It really doesn't look like your typical organized pneumonia, but could be. So anyway, a few little cysts in.
Maybe some cystic spaces. Yeah.
Yeah, yeah, and I don't know. This would be interesting. We can talk about that. So the only thing this patient had was they were a vapor, and guess they were vaping methamphetamine. So this is everything else was ruled out. They didn't find the infection or any underlying autoimmune disease or anything. So this is a recent, fairly recent case of EVALI I saw back in the winter. So it still occurs, but it's pretty rare. But this was from methamphetamine, which I had not seen before. And I presume the cysts are probably from inhaling vaporized whatever hot gases. So I presume it's related to that, and I don't have a better explanation. I don't think
Yeah.
when in our Valley paper, we did not describe cysts. We described some. We had actually no, that's not true. We had one case at least that it was one of the figures was an atypical pattern we called it, which is when we couldn't agree on it, and it did have some cysts. So EVALI from methamphetamine. This patient, this is a 23-year-old. This is interesting case. I was not aware of the full relationship. So this patient, as you can see, has a bunch of pulmonary AVMs. So of course we think about HHT. But what is interesting also, and I was looking at this case with the pulmonologist, was this guy here, and let's get the right window. These guys here in the liver. Turns out we have some liver imaging too. So these are some. Oh, that's the pelvis. Yeah, so we didn't get up high enough there. So I'll just show them on here. But anyway, these are FNHs. And then on top of that, this young person also has this. And this is a colon adenocarcinoma. And how do you tie HHT to liver things to colon cancer? Well, it turns out he's got the SMAD4 mutation, which is one of the mutations that causes HHT. There's I think four or something, maybe more. But it's also associated with colon cancer at a young age, and it's also associated with fibronodular hyperplasia of the liver. And he just happened to have all three at the same time. So if you do come across an HHT, it's important to check the liver, not just for AVMs, but for FNH. And if you have abdominal imaging or any weird signs and symptoms, they are at increased risk for colon cancer depending on their mutation. So SMAD4, SMAD4 is what it's called. I was not aware of this relationship, but now I am.
And it predisposes to malignancy.
Yeah, particularly colon cancers.
Wow.
Yeah.
Yeah, I didn't know the colon cancer association. That's good to know.
Yeah, I didn't either. Young guy too, like I said, early 20s. Okay, so this is cool. So this patient has a bunch of well-defined lung nodules, pretty sizable. Here is the CT scan. You can see this one has some faint lucency in it and a cavitation. And then we'll get to the one down here. This one also has some cavitation in it. And if we look on the soft tissue windows, we'll see there's some faint calcium in that one. There's definitely some nice central calcification in this one. And this one does not have any calcification. But then we see the calcified draining hilar and mediastinal lymph nodes. So these are, they actually ended up biopsying one of these just because they didn't know what they were. But these are actually histoplasmomas. And I've not seen very many cases with multiple ones, and they rarely cavitate. So this is a little bit unusual to see that. The one with the central calc, I think that's a straightforward histoplasmoma or tuberculoma, depending on where you live. But to have three in the same patient is kind of unusual. So that's why I saved this one there. So multiple histoplasmomas. All right, we've got a 13-year-old, and this patient had an abnormal cough and an abnormal chest radiograph and has that thing and all these things here. So if we look on the soft tissue windows, you can see these are nice cysts. So these are a kinococcal cyst, but this one has ruptured, and you can make out the little bit of the endocyst inside. You can probably see it better there. And then it's spread through the airways, and that's probably what's causing a lot of this cough. This one down here is also ruptured, and you can actually really nicely see the endocyst in there. So it's rare to see. I mean, this is a lot of hydatid cysts, but it's rare to see multiple ones all ruptured at the same time. But they can, when these rupture, they can they can get hemoptysis, and they can also spread a lot of inflammatory stuff in their lungs. The treatment is usually resection, but clearly this is not an option when you have multiple ones like this. This would be a pneumonectomy and a lobectomy, which you just can't do. All right, this is a 66-year-old. I'm curious what you guys think about this case. So this patient, this is another patient with pulmonary AVMs. It's a bad emphysema, but has these big AVMs. And you can see there's the vessels. But what I found odd about them was how little the vein and so the draining vein was, and how even the supplying arteries weren't that big given the size of the nidus. Even this one here, usually you see a pretty sizable tortuous vein, but here's the vessel coming into this one here. And then this one, the draining vein is just somewhere around in there too, but they're very small. I'm not sure if you've seen that before, but usually I've seen bigger ones. I don't know why they do that, but you can see these do fill with contrast, so they definitely are AVMs. But really, really big niduses on those. And then this last case is just, I don't know, you guys have any comments on that one?
No, very strange.
Yeah, it's just very strange. So this is a young guy, he's 38, has all these perilymphatic nodules. Some of them are, let's get the right windows here. Some of them are pretty dense. You can see pseudoplaquing here. And then he's got calcified mediastinal and hylar lymph nodes. So you might think of sarcoid, but this guy actually works in a mine, but he's only been in the mine for 6 years. But clearly doesn't wear any protective equipment. But this is pretty advanced silicosis for 6 years in a mine. You can see it goes all the way down the lower zone. So the perfusion is pretty high for silicosis and just that low exposure. But you can get called accelerated silicosis. It usually develops PMF within 10 years. And it takes, usually you see it more in sandblasters or people with higher levels of exposure. But I guess if you're in a mine where there's a high level of silica and you're not wearing any protective gear, you're at risk. So young person with really pretty bad silicosis. He hasn't developed PMF yet, but and I don't think he's in the mine anymore, but really nice example of the pseudoplaques you can see as well with silicosis. All right, so that's my little tour of some interesting things, and I will stop there, and I guess we will wrap it up. So thanks, guys, for participating.
I have a question for you, just completely unrelated, but it's quite common when I see reports of chest imaging studies that there's a differential diagnosis. And I get the sense that when people really don't know what's going on, they tend to mention, they say this could be infection, aspiration, or inflammation. And I always ask him, what is inflammation? It's not a diagnosis. I drive him crazy. But do you ever encounter that inflammation thing?
Or they'll say
Howard, that's
infection.
exactly what I said earlier with that radiation case at the lung base. There's exact terms I use that people will just generically say infection, inflammation, or aspiration.
Yeah, and infections are inflammatory. Aspiration is inflammatory.
Right.
Yeah, inflammation is not a diagnosis.
No,
and I actually encourage my
helpful.
residents, if you don't know what it is, or the diagnosis is not apparent, you don't have to be embarrassed. You can just say that. The potential etiology of this is not directly apparent from the images. And of course, you would like to go to the medical record to see if you can figure it out.
Right.
But the inflammation one, that particular one, always gets me.
Along the lines, particularly with radiation, I'm curious about the terminology we use, because I try to be more precise and say, like, I don't know, some of our oncologists don't want us to say pneumonitis, because that implies, like, radiation pneumonitis, because that implies that they may be symptomatic, even if they aren't. Or, one of the oncologists recently was like, well, we prefer if you just said radiation related changes, which.
Oh.
The changes are unchanged.
Yeah, unchanged changes, right?
Yeah. Changed changes.
Yeah.
We had this discussion on Monday. It's radiation-induced lung injury. That is a fact of life. And if it's stable and matured, you can call it fibrosis.
Yeah.
Yeah.
Sure.
Yeah, we should not. Call it what it is.
Yeah. Sometimes it is organizing pneumonia early on, right? Which again just gets to your point that it's lung injury. Yeah. But yeah, right. And then once it gets into that, beyond that 6-month time frame, and it stabilizes and you see clear-cut signs of fibrosis, then I just say radiation fibrosis next. But unchanged changes.
Yep.
I'm
sure David has an opinion. I remember him saying something about unchanged changes.
Yeah,
we had this exact discussion on Monday. It's so funny.
So,
all right.
All right. Thanks, guys. Good to see
Yeah,
you
Thank
again.
take
you.
care. Bye bye.
Cheers.
All right. Take care.
Bye-bye.